Okay, so let's then, I say, for the latter part of this discussion, then think about some clinical examples, and also maybe get a bit more about nomenclature. Again, I hope it's fairly well known, is that the suffix itis is often used to describe an inflammation of a particular body part. So appendicitis, we've talked about a fair bit already, conjunctivitis, meningitis, pericarditis. Do you know what funisitis is, John?
No.
Well, I hoped you wouldn't, because I'm going to leave the readers.
I have no idea where my funis is. Do I have one? Do boys have a funis?
We all had a funis at one stage.
Oh, well, do tell.
Well, it's actually the umbilical cord.
Really?
So funisitis is just a peculiar word that means inflammation of the umbilical cord.
Oh, I've never heard
but
that before.
It's just, itis.
And do we have an etc.?
No,
as well?
That's where the list ends.
Right.
Okay. So that's fine. So this is now just to say a number of different examples of the inflammatory response at play in a clinical setting. So here is a patient who's actually had a myocarditis and has developed a pericarditis.
So this is the heart.
This is the heart sitting towards the left, and what we've done here is we've opened the pericardial sac, being stretched off to the right, and the arrow is pointing to the pericardial space.
Yeah.
And within the pericardial space you can see these strands of material which are essentially very rich in fibrin. So because it's on a serous surface, the exudate, rich in fibrinogen from the plasma, has then produced fibrin strands, and this is and the polymorph neutrophils are also in the area, so you're getting a fibrinous pericardial exudate.
Yeah, so that can't be very good for you.
Not at all, not at all, no. Okay, so that's one example. Here's an example of an established peritonitis. I think this was due to...
So here's some small
bowel loops
all stuck together.
So the abdominal cavity.
Bit of momentum up here, maybe.
Yeah, that's right. And again, we've got this now a fibrinopolant change. So often when there's an established peritonitis from potentially an appendicitis or from perforated diverticular disease, you again see, because we've got a lot of surfaces over the abdominal spaces, you've got lots of fibrin produced on a surface with pus cells, giving you this classical fibrinopolant exudate.
And you see all this stuff, and
it's all stuck together.
Yeah, when you get in there, you probably don't have to do it while there's still any danger of complications, but it's all stuck and horrible, isn't it? It's really
so that's another classic example of the inflammatory process at play. This is
your cat. For you.
No, I'm not sure who this poor patient was, but you can see here a patient who's been bitten by an animal, and you can see again the classical changes of inflammation. You've got swelling of the area clearly. It's red, and there's some. I'm sure there'll be some discomfort and pain. The patient would be using their hand very easily. So again, the classical features of an acute inflammatory response. This time, of course, there's a potential difficulties with the animal bite carrying a number of bacteria, which have been then deeply implanted into the tissues. So the body is going to be at some difficulties in trying to eliminate that. The patient clearly maybe would benefit from antibiotic therapies.
So cat bite's very nasty because it's got long, sharp teeth. Human bite's even worse.
Apparently, that's right. The bacterial flora are very nasty in the mouth, as you say. Yeah. Okay. This is an example of a meningitis. So we have.
So this is from an orthopaedic surgeon because they weren't using it. So is that right?
I couldn't possibly comment. But on the bottom left photograph, you can see what we have: the cranial cavity opened, looking down from above, and we've reflected.
So the skull's gone.
The skull is exactly.
And then here's the.
And this is the dura, which has been reflected back, and you can't see the normal surface. Gyri and sulci of the brain. Instead, it's replaced by this rather
sticking up like islands, can't you?
Exactly, but rather this horrible, rather yellow-green material. And this is an example of a really quite a raging, nasty bacterial meningitis.
It could be quite bad for you to have this view, I suppose.
Exactly. So sadly, the patient
terrible,
passed away from meningitis.
Yeah.
Okay. Here's an example from the lung. So we talk about numbers of different ways in which the lung responds to inflammation. We think about lobar pneumonia and bronchopneumonia. On the left-hand side, you've got a left lung here with a relatively unaffected upper lobe, but the lower lobe is really quite firm and pale. This is a relatively later stage of acute pneumonic consolidation, so-called, and learning as we have about the inflammatory response in the lung, we can, rather in general, in the lung we can apply that knowledge and say what's happening in the lung is that the alveolar spaces, the air spaces, are literally being packed out by polymorph neutrophils. And in the initial stages, that makes the lung very red and firm. And in fact, old-fashioned pathologists, of which I am sadly one, would often talk about hepatonization of the lung.
So it looks a bit like the liver.
Exactly right.
It's red and firm.
It's so red and firm it looks like liver. So hepatonization. So red hepatonization, and then as resolution begins and the polymorphs start to dwindle and macrophages move in to eat up the debris, then you talk about grey hepatonization, which is where we're at here.
Okay, so this looks like a big lump of foam or something.
Absolutely,
or even
it's very alien to what normal lung should look like.
Yeah. Okay, and there's clearly that's sort of honeycombed, and that is just solid.
It's completely solid.
And so you can see why it's too difficult to breathe, and then the clinical signs that sort of transmit the sound better, so you have all those those signs of consolidation.
Exactly, delta percussion and so on.
Yeah.
And the other right hand side is just a similar process, but this is now occurring in a much more patchy way in the lung. This is a bronchopneumonia as opposed to a lobar pneumonia, so you get just areas being affected rather more haphazardly in all lobes of the lung, and this patient's probably got a degree of chronic obstructive pulmonary disease, in that although it's not very well shown, perhaps towards the upper zone there's a little bit in the way of emphysematous change. The lung has collapsed down. It's not quite as full on the apical lobe there.
Yeah, and it looks like that because the big air pockets, which have the air's escaped, because it's you've got it on the bench and the air's just collapsed, and so the whole thing's sagged down.
Yeah. Okay, that's good.
Like a crisp packet when you've opened it.
Yes. Okay.
I know pathologists like food analogies. So.
Yeah, yes, we do. We do. Yeah. Okay, so we're sort of coming towards the end now. We now can just revisit this diagram that we showed earlier on, which, as I say, looks at the sequelae, if you like, of the inflammatory response, and we've discussed, haven't we, how this is characterised by vascular changes, cellular migration changes, and so on. And depending upon the tissue that we're looking at, we can either lead to, and the extent of the damage, we can either lead to a situation of resolution and the whole thing being restored back to normal, or if the tissue has been damaged and it can't repair itself, then you get scarring and fibrosis, healing by repair by scarring, or if the injury persists, as I say, moving on to chronic inflammation. And at some point, hopefully, we can go on to discuss chronic inflammation as a separate topic, thinking about how the body's responses vary in a chronic inflammatory setting, with different cells being recruited in order to try and repair the injury. And just as a sort of prelude to that, here are a number of just different photographs taken to show this chronic inflammatory response. I think the rather dramatic one here on the right hand side is I think of a patient who was using intravenous drugs, and this is the sort of changes that can occur in the skin because of ongoing persisting injury. The others, it's just where there's been area of tissue damage which is not resolved. So we can think about specifics next time, perhaps. But here's an example of a lesion on the chin where either because there's been repeated injury or because of the nature of the infection, it hasn't resolved, and it's been sitting there for some time, and this has now moved on to a chronic inflammatory response. Okay, and if we then just think about one particular, if you like, as a prelude to as a classical example of the chronic inflammatory response, here's a chest X-ray taken from a patient who has what looks like a sort of cavitating lesion in the upper part of the right lung there, and this would be very classical for a tuberculous infection. And tuberculosis, as I'm sure we know, is a sort of very classical example of a chronic inflammatory response, because the mycobacterium that causes tuberculosis has a number of strategies to evade the acute inflammatory response, as it were. The acute inflammatory response is not sufficient to overcome mycobacteria. We always move on to this chronic inflammatory change, and we then move to chronic inflammatory changes in the lung with abscess formation and mycobacteria. So
this was full of pus.
This was full of pus, but in fact not so much pus, because it's now in fact not really pus, to be honest with you, because what we're saying here is this is the chronic inflammatory response. So the cavity is actually just destroyed liver tissue, destroyed lung tissue rather, and is maybe filled just with debris, and has in tuberculosis a particular feature which is that of granulomatous change. Granulomatous is a particular word that we'll think about another time. So we wouldn't actually see much in the way of pus in that cavity, rather just destroyed lung tissue. Because
as we said, pus is polymorphonuclear
cells, and these are the cells of the acute inflammatory response, rather than those that characterise a long-standing abscess such as this one. And I think that is a cue for us to stop.
Okay, so that's fantastic. I mean, there's a lot in there, David. Thank you very much for taking it through very clearly. So, just summarise a lot in there. What's the key take-home messages? 2 or 3 things that everyone should remember.
Sure. So I think from the podcast, what we'd like the listeners to have is now a better understanding of what the acute inflammatory response is as a stereotypic response to injury, to understand that it has these 3 basic components, as we've said, of the alterations in the vessels, the migration of cells, and the orchestration of the response by a number of chemical agents, and also to have seen the inflammatory response at play in a number of different clinical settings, and its relevance obviously to clinical medicine.
Great. Well, thank you very much. We'll be hearing from you about chronic inflammation in the near future.
Okay, I hope so.
Okay.
Okay.
Thank you very much indeed.